Okay, so premature junctional contractions, they're okay. They're not overly exciting. But now we're going to get into what it looks like when the AV node is fully in control. And this is called the junctional escape. So I'm just going to share my screen. This is called the junctional escape rhythm. So this is what it is called when the AV node is driving the train. Now recall, we've talked about this before, but just to highlight it here in case you've skipped over a few lessons, the AV node has an intrinsic firing rate of 40 to 60 beats per minute. So when we look at a junctional escape rhythm, we will find a rate of 40 to 60 beats per minute. Characteristic feature number 1. Because recall the SA node will beat from 60 to 100 with a P wave. Characteristic number 2 is that there is no P wave, or, as we talked about in the introduction, inverted before or after the QRS wave. Now that AV node can take over when the SA node completely fails, or when the SA node is so slow that the AV node is not getting stimulation. This serves as a protective mechanism to prevent ventricular standstill, which is also known as asystole, which is also known as death. So we have our primary pacemaker, SA node, and then we have our first generator backup here, the AV node. Now the junctional rhythm will initiate within the AV nodal tissue, and we can also have an accelerated junctional rhythm as well, which we will talk about in the next section, where there's an enhanced ability for automaticity. The automaticity is the ability to generate an impulse. So let's look at this in comparison to normal sinus rhythm. It definitely looks slower at the beginning, but I don't know if it's a sinus brady. I mean, it could very well be just at first look. It looks pretty regular, like I can rely on that beat showing up at a particular moment in time, which is consistent with normal sinus rhythm. This is also regular. My QRS is narrow. QRS is narrow. I have this round T wave and a round T wave. And then there's where the missing link is, that P wave. So 2 characteristic features, the P wave change and the slow heart rate. But again, without doing our analysis, someone might think this is bradycardia, so we need to take a look deeper. Rhythm R to R will be regular. The rate is between 40 to 60. Junctional escape rhythm. P wave, inverted, buried, absent. PR interval will be narrow if it's present, less than 0.12 seconds. QRS complex will be normal between 0.06 and 0.12 seconds. The QT interval will depend on that underlying rhythm. Here, this one looks like it might be 2.40 seconds, just roughly looking at that. And the normal QT interval is between 0.36 and 0.44 seconds. And the ST segment should be flat. But if there's digoxin toxicity that is driving this arrhythmia, you want to watch for that slurred, sloping S wave, that rounded dig wave. So common causes, vagal stimulation. When the vagus nerve is stimulated, it enhances the slowing of the heart rate. So people who are bearing down, holding their breath, coughing. Digoxin toxicity, which we talked about in the last section. Inferior wall MI, we talked about in level 1, and rheumatic heart disease. So we're going to talk about rheumatic heart disease next. Now, this arrhythmia may be a result of rheumatic heart disease. And what happens here is we have these antibodies that are as a result of a bacterial infection, in particular Group A Beta-hemolytic streptococci. And what happens because those bacteria seem to settle on the mitral valve, and that they tend to prevent them from closing properly, and this affects blood flow. Now, as I mentioned, it is as a result of Group A Beta-hemolytic streptococci. But when we look at these 2 different pictures, which one do you think is strep throat? The first picture here is sore throat, typically viral in nature. It's red, it's beefy. It doesn't look very nice, but it's not strep throat. Strep throat here, you notice the swelling, and then you can see the white plaques here. This is a consistent strep throat appearance. And if strep throat is undertreated or mistreated, a patient is at higher risk of developing rheumatic fever, which leads to rheumatic heart disease, where the bacteria affects those valves. Now, rheumatic fever can occur after just a single episode of strep throat or after repeated episodes of strep throat. It's not a guarantee it's going to happen, but it is a risk factor to the development. So if you work with patients who have had a mitral valve replacement, have a little discussion with them and see if they had strep throat as a child. I'm curious to know if there is a higher percentage in your patient population with that connection. Now let's just take a look at some of the numbers here. This comes from nurseslabs.com. So I wanted to share a little bit about what she summarized on rheumatic fever. Major cause of mitral insufficiency and stenosis. Over 15 million cases worldwide, which is higher than I thought, and 282,000 new cases a year with 33,000 deaths. That's significant. It's principally a childhood disease. We know that. I've had strep throat, most commonly between the ages of 5 to 15 years, but this can certainly develop in adults, and that's when I first had it actually, was as an adult. And it doesn't discriminate between gender. So let's look at the Jones criteria. This initiated in 1992, was revised in 2016 to provide guidelines for making the diagnosis of rheumatic fever. Now, in this case, we're looking for the presence of 2 major, that would be consistent with a diagnosis of rheumatic fever, or we can have 1 major plus 2 or 3, or we can have 1 major plus 2 minor, or the presence of 3 minor criteria would be consistent with a diagnosis of rheumatic fever. So in terms of the major, if we were to have mono or polyarthritis, so this is one joint or multiple joints that are irritated and inflamed. Chorea, so this is jerky, uncoordinated movement. In some cases, there is damage that happens at the basal ganglia that results in this uncoordinated spastic movements of the hands, the feet, and the head. Subcutaneous nodules, these are small and painless bumps that are under the skin. Erythema marginatum is a rash that develops in the subcutaneous tissue. Here we have a picture. It forms rings, it doesn't itch, and it just kind of spreads over. And it may also have a ragged edge. It doesn't always have to have this beautiful, beautiful edge here. And then carditis, inflammation of the heart. If we have 2 of these present, diagnosing rheumatic fever. If I have 1 of these present, I need to also have 2 minor. So that would include a fever of greater than 38 degrees, ECG changes where the PR interval is prolonged. We may have an increased ESR or CRP rate, and polyarthralgia. So in the absence of any major symptoms, I can have 3 minor, and that would result in a diagnosis of rheumatic fever. So perhaps I have a fever, I have a prolonged PR interval, and I have multiple joints that are irritated and inflamed. That would be a diagnosis of rheumatic fever. In terms of treatment, antibiotics is the main treatment for strep throat. The problem is some people don't finish their antibiotic treatment, and so this is where the risk comes for rheumatic fever. We want to make sure that patients are taking their full antibiotic regimen. Using antibiotics to treat your throat infection is preventative for rheumatic heart disease. So make sure, if you know someone who has strep throat, that they take all of their antibiotics. Even when they feel good, finish off the whole thing, because we don't want to put them at any further risk for developing rheumatic heart disease. Other things that you may see being ordered are anti-inflammatories for the arthritis, corticosteroids for the inflammation. We're going to restrict that fluid and sodium. Surgical intervention may be needed as well. Anticonvulsant medications for the tics the uncontrollable movements, and decreasing their activity will all help to treat rheumatic fever. But treatment of a junctional escape, now that was just one cause. Treatment of junctional escape is look for that underlying cause. And if they become symptomatic, we are going to pace them. Now, some of the causes we've mentioned are heart disease, heart attack, electrolyte imbalances, alcohol, stimulants, nicotine, caffeine, digoxin, hypothyroidism. We need to do some investigation. So at this stage, we will be ordering lab work. We'll be looking at ECGs, potentially more than one. We'll be doing a health history. We might be looking at x-rays. We might be sending off diagnostics for ultrasounds. We're not sure what they need at this point, but we're going to dig in and find out what is causing their symptoms. In our next section, we're going to look at accelerated junctional rhythm. We take the junctional escape and we ramp it up just a little bit.